Foreman. However we want to go with it. But April is on our board of directors, and she's on the executive committee, and we are going to learn all about her this afternoon and have some great conversations about AAS, goals for the board, all sorts of really cool stuff. We are still in National Suicide Prevention Month, so I want to invite folks to go to aas365.org to find resources, stuff they can share, stuff they can do personally or here in the last couple of weeks of the month. So go check that out. I guess it's not even the last couple of weeks, is it? It's the last week of National Suicide Prevention Month. So go check that stuff out. But thank you, April, for joining us this afternoon and sitting down and chatting with us.
Well, I'm excited to be here. I've never live streamed before. I'm very nervous. Never. I feel very shy.
I think you'll be okay.
I think we'll be okay. Well, I'm very excited. I know that some people will catch us live, and some people will, in fact, see these live streams later. I've been on the board for a little while, and I have definitely, we did years of SPSM, so I feel like in some respects, this isn't a new entity, but we are excited to talk with folks. I know that this was, a part of a planned effort that we were going to really engage the board with organizational communications. And then I think reasonable people who've had a lot of experience with the organization definitely want us to, during Suicide Prevention Month and sort of going into October, as we're working on mental health awareness, and as AAS is working on strategic planning, as we've scheduled, talk a little bit about who we are. I've got some questions that have been prepared, but ultimately we of course always appreciate engagement. We do what we can to take questions from you all, and I guess we can get right into it. Chris, do you want me to announce the questions? Did you want to announce the questions?
No. This is going to be this is going to be a conversation. We've had a couple of these so far, but really, I want to know. I'm sure that there is probably going to be some stuff in our conversation that I did not know about you, but I know that there is going to be a lot of stuff that others don't know about you. So I think that's what we're trying to get out of this. And I guess the easiest way to do it is just to jump in and to have you kind of introduce yourself. Who are you? What do you do? How did you get into suicide prevention in AAS?
So my mission in life is to relieve pain. I'll do that one person, one problem, 1 minute at a time if I have to, and I'll be more effective than that if I can. And I am really grateful that I get to do that a number of ways. I spent some time getting to understand myself and what sort of makes me tick, and understanding that that's just who I was fundamentally has really driven a lot of my career choices. I've lived that mission in a variety of ways. I've worked in mental health in some way or another, pretty much since graduate school. So back in the mid 1990s, don't tell anyone. And also had been a yoga instructor and tended to always pick things like restorative yoga. I worked at a senior citizen facility doing like recovery after medical issues. Like I always, when I pick things to do, I tend to pick things that are about healing or about getting well and about relieving pain. I had, in my graduate school days, had been focusing my research efforts on positive psychology and on how to train exceptional graduate students, and especially how to train students who are both good clinicians and good researchers, because you often sort of get clinician-focused graduate students who maybe don't love research so much. So like, how could you make that better? Like these are things I always think of. And I was really heading down that path, that's what I was going to do. I was going to work in academia and I was going to train. And I took sort of a detour. And one of the things that we figure out about life And I think you may hear there's a ladder going on. So so we're gonna work through some construction here. I'm about as far away from it as I can be, but these are them's the breaks. But I had taken a detour, and I had very suddenly needed to move back to rural Kansas, where my family, my husband's family are from, and to be near our husband's family. And I was living in rural Kansas and southeast Kansas, and there was like a job, and that job was working in community mental health, which is something I did not want to do. And I showed up, and I know that, you know, you won't be shocked. In fact, people generally are not shocked that when we look at things like community mental health, or we look like rural mental health care, that in fact in the poorest and sickest counties in rural Kansas, you didn't have that sort of full complement of evidence-based care that you would usually expect to see. And I definitely showed up and saw folks that were not getting well, they're high risk of suicide. And we had folks with borderline personality disorder that just really weren't getting the evidence-based care that they needed, and were not getting well. And dirty little secret, those are the folks that the agency made a lot of money off of. So you could just bill and bill and bill and bill services, and people could just stay pretty sick and need lots and lots of emergency things billed at higher rates for literally a decade. And they could be $1 million patients. And you might use the word patient, client, consumer. I know people use different language, but I'm just going to pick one that I feel like universally people know what I'm talking about. And it really bothered me that folks were not getting what I, as a person who wanted to train therapists, knew was the appropriate care. And that we were making so much money not doing it. And I was making like a food stamp wage. I was making like some of the least amount of money I think I ever made in my life. However, I thought, well, we can do better than this, and had gotten, got a coach, and I was really like trying to figure out how I was going to live in rural Kansas and how I was going to help folks. And I was in despair because it felt like everything was stacked against folks getting the care that they needed. And just got some great coaching and great advice, and figured out how to open a DBT clinic, how to get training and open a DBT clinic with like no resources. And also figured out how to use technology to assist some of that with mood tracking. I did some of my first collaborations. We did a collaboration with Health Central and Johns Hopkins, which is one of my first big projects. And that was when I got to understand that it was important to help folks with this high risk, that people with borderline PD would die by suicide 3 to 10% of the time. Like, this was a lethal diagnosis that we were not giving evidence-based care for, and that there were technology tools that could help extend my ability to connect with and the impact of some of our therapeutic interventions. And we did some great client-centered care, and I'm always going to be proud of those projects. And that sort of love of doing that did not intersect with what was happening regionally at the time. There had been real constraints about being able to provide care, even in very like limited ways. And I started doing a job search, and I ended up working at VA. I'm only speaking on behalf of AAS, not VA, but I ended up working at VA. Because it turned out that there was a real need for folks that wanted to do care for folks with high liability, lots of risk factors. And they had a job called a suicide prevention coordinator, right? And Bill Schmitz, who's one of the AAS past presidents, had an office just down the hall. And he's like, suicidology is a thing. Suicide care is a thing. There are standards. You were very likely not trained in it, because people just aren't. You can get a PhD, you can get a clinical license, you can never get properly trained. And that's usually the case 9 out of 10 times, according to our research. And certainly for me, it's not the case. And so that sort of real sense that people with the greatest need and greatest risk were most likely to get care in places where they weren't going to get the standard of care, that most therapists were never going to be properly trained. And that those were the folks, I mean, that, whether they say call the lifeline, go get help, like get yourself an appointment, right? And then when you get there, for us to not be trained and ready for you, like that's BS, right? So I became involved in suicide prevention, which was sort of not where I wanted to go at all, but because there was a real need. How could I have a PhD and not know that suicide was the 10th leading cause of death? How could I have a clinical license and never have been trained in some of the fundamentals of assessing suicide risk and safety planning? But I never was. How is it that this is possible over most of the world, and especially in the US and many places where we have licenses? Once I understood the size of the problem and the size of the need, that was it for me. And so here I am, right? Um, I think there was a moment when I first got into suicide prevention where I thought I was going to meet all the grown-ups who had everything figured out, and they would just be, well, you just do XYZ. This is how we've always taken care of the problem. But it was in fact all of these great experts who were the ones teaching me what the size of the systemic problems were, and you just can't ignore that.
It's the grown-ups comment reminded me of the first time that I went to an AAS conference, and Bill Schmitz was actually the first person I ever met at one of these conferences, and he cursed at me in the elevator, and he will not be ashamed that I mentioned that. But no, we have this idea. I think until you enter the realm of suicide prevention, there's this idea that all clinicians are trained. They're all aware of how to handle the situation. They're all aware of what the scale of the problem is, and that there is one answer, and that it should just be done that way. And it has something to do with hospitalization or whatever, right?
Oh yeah.
It's something that like, we see on TV or whatever.
Well, and at that, no, I don't even just we don't even just see it on TV. Like, I got to that community mental health job,
right?
And like, if someone's suicidal, you just called the crisis team, and I was like, listen, this person's expressing suicidal ideation, and then it was to your therapy session, we're just gonna wait until the people who know how to do this show up, as if and I had the more training, which, well, right, technically, but not really. That's nuts.
Well, and then as soon as they get there, it's off your plate, right? There's nothing, because it's handled.
Totally,
it's taken care of.
The stuff you need to do is
it's not.
I'm not to say simple or whatever, but it's pretty standard. You can learn it.
Right. Well, and so, but yeah, so going to AAS for the first time as a conference, I expected to go to a few sessions and have them be like, okay, well, this is how we handle suicide. These are the answers, and we've figured it out. And it's like, no, here's a nuanced approach, and here's a nuanced approach, and here's what we know about this data, and here's what we know about that data. But nobody was and it's still really hard for the field, I think, to put all of that together to something coherent.
I think there was at an AAS conference, we had sort of the big ideas in suicidology, and we were sort of talking what's next.
Yeah.
I think it's fair to say that there are really only about 3 things that we really know and have great evidence base around for preventing and resolving suicidality, so preventing death and resolving suicidality. And there are a lot of other things besides that, like you said, here's an idea, here's a thing, here's a thing, here's a thing. And I often also talk about the Uber driver theory of suicide. There are as many theories of suicide as Uber drivers that I've had, because they always ask what I'm doing when I'm back in the before days, before the pandemic, where we were traveling a lot. And they'd be like, what are you doing? And be like, well, this is kind of, no, I do, suicidologist, right? And they would tell you, they're like, I know why people kill themselves and what we should do. And there was a lot of that. And I think one of the things that I really came to understand, it's not that there isn't a lot of value in all of that broad variety. It is that there has been not nearly the support for all the science and the cohesive theory building and things like that. So we know, that dialectical behavior therapy and similar, there are a few clinical approaches that have some clinical trials with them, but not very many. We need to pay for more. We know that that lethal means restriction and lethal means education works. So we know that if something's highly lethal and very easy to get, that if we make it less easy for people to get in general, we know that reduces your overall death rate, just like seatbelts and airbags and better highway engineering does. We just make Suicidal feelings don't kill you. Other lethal things kill you. So like, what do we do about that? And then we know that caring contacts. So we know that like non-demanding caring contacts from the people who are trying to help you. So like that if you call a crisis line or if you go see your clinician or whatever, that if you get routine, non-demanding caring contacts, even if you very much automate it, that seems to reduce risk of escalating suicidality, attempt, and death. And then there's sort of this big other menu of things that need more science and that need more research. But unlike the other major causes of death, there isn't this, great, huge pile of money and great, huge, that we do have a little budget at the NIMH. There are wonderful people working on that. Big shout out to Jane Pearson and others. But we do not fund science at the scale of the impact of death. And we certainly don't fund science at the scale of the impact of suffering when we know that 8 to 10 million Americans probably have been at high risk for suicide this year. And it's lethal emotional pain. And you'd think we'd pay for more science for this. You would go to an AAS conference and you can see lots of ideas. What we really need is, in my opinion, the funding and the support for the science.
And I think, the conference itself acts as a nice sort of central location for people to make the case for that. That they can, and I'm not trying to pitch everybody to the conference. I'm just saying that, like, I think that, to my earlier point, it's not that we don't know what's going on. I think it's that people are trying to find out and how to disseminate that information in an effective way to then advocate and lobby for that additional funding and research. And we see, like right now, initial conversations about 988 started at the conference, right? And how big that has become in our at least in the crisis world in our lexicon over the last year and a half, and what that's leading to in terms of funding for intervention resources, right? I mean, a little bit about this. And how much that's helped in terms of the resources there. But we can't make those cases without having these conversations and really knowing what we're talking about and knowing what data we're working with and having real-time data. I'm not going to get into that rant again because Tony and I just did that.
Listen, if we want to start with a discussion of how can we reform the science, one of the answers is not just making funding available, but making data available. If you want to do that, you've got to have, like, just to start as many people at the CDC and just to start the kind of data collection infrastructure that we have, for example, that we stood up for COVID almost immediately, that we stood up for the opioid crisis. When we, one of the things that really occurred to me when I would talk with my colleagues at the CDC, and they were like, well, there's only 6 of us. And like Sesame Street, I was like 6 for data for this for the whole nation. And I think then they bumped it up to 9. And I'm like, well, how many are like for the opioid crisis? Oh, well, they stood up 100 people for that. How many are in England? Well, you talk with Nav Kapoor, and he is like leading, I want to say 34 data scientists, and that's just for health system usage relative to suicidology. So like it's not as if when it comes to suicide, we've tried everything. And in fact, really, really basic things like how do we count it? Do we have even like the basics of a really good data infrastructure? Do we as a nation, do we think it's worth like paying for more than like, say, not enough people to, to run a volleyball league, like, but really,
right.
truly, like,
right.
do we pay for enough people to do that? Do we use technology? Do we use more than coroner reports? How do we know how many people are impacted who don't die? How do we know real attempt data? Like these are find outable things. So how do we ensure that we do basic things like count and that we make data available to scientists so once the funding's there, the science can happen? And I mean, like, these were the things we talked about. The grown-ups, Chris. I showed up and the grown-ups were like, oh, they were like, you think this is bad, let me tell you about this problem. And this was like, I'm like, why don't the conversations that happen at the conference, why don't those happen in front of people who can make decisions about information and data infrastructure, about scientific funding, about how care is reimbursed? Like, why aren't they hanging out with us? Is questions I've asked myself.
Well, and I think that's a struggle for everybody to make sure that all the people the stakeholders that are necessary to make the real changes are involved. Although I don't know that struggle is the right word, and I don't know that it needs to be a struggle. I think this is something that, at least in my experience, has been a relatively universal uh, kind of topic to jump on the bandwagon with. Once you say like, oh, well, suicide prevention needs more money, people are like, well, how much does it get? And you're like, well, a sixth of what the dietary supplement research budget is.
Right.
And people are like,
Right.
what?
We're doing more looking into your multivitamin than we
Right.
are
Right.
people who die.
Which still is not FDA approved, right?
Oh,
So
no.
like, so well, and so that's um, we have our questions. I think one of the things I wanted to ask was like, what would you want to see change in the field of suicide prevention? If if it's not this, what else?
I mean, how about more? I would love for us to simply do. I mean, would I like for all my dreams to come true? Absolutely. But like, to start, why don't we just fund and develop the same public health and regulatory and care infrastructures that we do for anything that kills the same amount of people? Just to start, just the same as anything that causes this much health impact. That's all I want. Do we not, if this is something that kills people, if this is something that interrupts people's health and impacts their life long term, and it does at a huge scale, can we just collect as much data? Can we just put as much into our research and science? Can we just design healthcare and reimburse healthcare just as much as we would for the flu or like, I think asthma, we like outspends us. And like, I want to do things for people with asthma. God, people like my dad had severe asthma, about killed him as a kid. I get it. When I look at the private and public funding for HIV research and how HIV ends up into public health policies, like even at the city level, could we just treat suicide the same as anything that has the same impact?
I mean, yeah, but no.
Yes, we can. So if we don't, it is because we do not want to.
Right.
And that is the thing. When COVID hit, like that sense of if we wanted to, we could do something that fast. Or when the opioid crisis, really came to folks who were decision makers. We knew that it existed in other parts of our communities, but when it happened to someone who looked like you suddenly, but there was money, there was data, there was all that. We can do that. So when we don't do it, it is because we decided we did not want to, and that is not okay with me.
Yeah, the priority has been sort of backwards for a little bit. And one of the things you pointed out earlier too, I think is important to focus on, is that it's not just deaths, right? It's most
people don't die; they just suffer.
The huge amount of suffering and impact on other people that brings too. I mean, we talked about in the conversation with Tony last hour that we get somewhere between 45 and 50,000 deaths a year from suicide. But when you look at the attempts, and this is just an estimate because we don't have good data on it, but somewhere between 1.5 million attempts a year, and that doesn't even count. Right, and that's just in the U.S., and that doesn't count the people that have thoughts of suicide or chronic issues with suicide. So
correct, and that's excruciatingly painful. And so you're like, well, this is a painful condition that affects millions of people in the US and millions of people across the world. And it is excruciatingly emotionally painful. And we can't be bothered to have more than 9 people counting it in the US. Come on, we can do better. Do better.
Well, we can I mean, that's the thing that, you know, legislatively, it's hard to focus people in directions that I think are going to make the most impact, because when you start talking about data collection and analysis, it gets really boring.
No, no, it doesn't.
For a lot of
I am
people.
looking at COVID infections and death data every day on CNN with the hot map.
I
Data
know.
is sexy. It's interesting. We are fascinated when we want to be fascinated.
Right.
I think that people should and could be very interested in suicidality data if we were to provide it. And
Mm-hmm.
this is another beef. I know. Dr. Foreman has beefs. No one is surprised who's met me. But this is another beef that I have. This is when we started, some of you may know, we did the suicide prevention social media chat on Twitter, and then, you know, live streaming for many years. And people are like, nobody wants to talk about suicide because it's so uncomfortable. We had zero problems having public conversations about suicidality that were some of the most highly engaged, far-reaching conversations that attracted stakeholders from all over. It was never that people don't want to talk about it. It was that people were boring when they talked about it, or we just didn't choose. It's one of the most dramatic healthcare stories you can tell, and it's one we could be telling every day in an engaging way, and for whatever reason it just wasn't happening. And that's also a matter of will. One of the things that I have learned about this is that this is a matter of will. There isn't something getting in our way except for wanting to.
Yeah. And Thelking, which they're up in Canada, right?
Who?
The M Thelking,
Oh
they're
yeah,
here. They're here for your beef, is what's happening.
they're here for my
Um,
beef.
yeah, you said you got beef, so they're here for your beef. Um, that's a little
Oh
emoji of
my goodness.
a hamburger. It's perfect.
Totally glad, Em, that you're here for it, because like this is one of those things we talk about. Folks who are impacted, who have lived experience, who live with suicidality as a chronic health problem, and then we have, and because most people do not die, most people go on to live, but it's not like you were suicidal for 30 minutes and it passes and never happens again. It's usually a chronic issue, right? And hey, how's it going? I'm only just across the water from Canada right now. I'm like 4 miles away from like the Ontario beach. I could like dog paddle over to you. But like we know that, and this was so important to me, that there are so many impacted family and friends who might love
Yeah.
somebody at risk of suicide, who they will be impacted by the pain of someone they care about. They may be a caregiver, they may be helping somebody at risk, like literally people will call me going, someone I know is at risk, what do I do? And it's stressful and painful for me. And like when you think of the millions of people who are going to be involved in a suicidal crisis, or who will be involved in managing chronic suicidality, that's really a lot of folks. We can do better.
And I want to make sure that I'm not ignoring Jose too. Jose Ceballos from the National Coalition and Suicide
Hey,
Prevention over there in Panama. He's joined
Panama.
in a few times, and I appreciate you saying hi. Also talking about youth suicide rates there, and that was something that, you know, we've talked about a lot, obviously, April, and that how is it that when we're looking at suicide prevention, like overarching suicide prevention and what we know about suicide rates, that we can have, you know, the youth rate in the U.S. at least as the second leading cause of death for
And it's
youth
been
in
like
this
that a
country
while.
for a few years.
Yeah.
But we also know that rates with veterans and active duty military are not great. That rates with middle-aged men are not great, and that so we have all of these chunks
Folks who
of,
are transgender, very high
yes,
risk.
LGBTQ plus in general. Yeah,
And we know that rates of risk fluctuate, and we don't always entirely understand why. We should put
rates
some energy into understanding why.
rates particularly in Black youth have gone up in the last couple of years.
Which was in prior, not like this was,
Right.
that was a lower risk group. So we don't understand what's elevated the risk. We have Uber driver theories. where you, and I always made that, where you talk with somebody and they're like, I know what's happening.
We
But
got
we
one yesterday.
don't
Yeah.
have the science for that.
Yeah.
And I always sort of hesitate to say, I know what's happening, because like, science, right?
Yeah. What do you, I want to stay on. I want to stay on this, but I also want to try to focus on.
Get me through, Chris. We've
I
done
want
this
to.
rodeo
No,
before.
I know.
Get me through.
But kind of along these lines, what do you want? What is your biggest priority in suicide prevention? We talked about what you want to change, but what's your biggest priority?
So there are a lot of folks working on several of the issues that we've talked about. And so of course, anytime, a few years ago, Chris, and you know this, we worked on standing up committees and organizing people around messaging and around creating a public conversation, like, because there are plenty of experts who want to say these things that are like shocking almost and painful to talk about, like all these things that I've talked about. But for me, I would tell you, like, where I think I have a unique contribution to make. I would say that I am fascinated by emerging technology applications in suicidology, and there are several that I think are coming or that are already here that we as a field could be using to accelerate science and accelerate policy and accelerate care, and we need to understand those. So I think about data science that has made detecting suicidality and predicting risk of attempt or death months prior, when a person may not know about their own risk. Like, we know that that's possible. What are the ethical and appropriate uses for that? Using broad social media data to help understand population risk. We used some of those techniques at the beginning of the pandemic to see how overall suicidality and risk changed rapidly across the US, which we could show, and showed how it was different for folks in healthcare and elevated for a time for folks in healthcare. And so, like, that was like some real time or near real time data collection. I think that we need to be talking about appropriate use cases for artificial intelligence applications in suicidology. I think that a lot of things that people propose right off the top of their head, like, I'm going to do a keyword search of the internet and it will find the suicidal people and we'll grab them and save them. Like, I see that as a proposed use all the time, which there are a lot of reasons why things like that are not a good idea. And there are really good ideas that we're not talking about. We need ethical writings on this. We need best practices developed. I think I've got a lovely 15-minute bit on what we need for mental health and suicide prevention orgs to be doing right now with their data and their infrastructure to be able to use artificial intelligence, machine learning, and natural language processing tools that will be widely available in the next 5 years in the service of our mission. So I would love to help with some of these emerging technologies, help mental health and suicide prevention, which was 14 to 17 years behind adopting emerging technologies in comparison with the average business. I would like for us to just keep up with those things in the service of our missions, to not be slow.
Jen Carson emphatically agrees.
Yes,
Ethical
I totally
innovations in suicide prevention.
algorithmic injustice, and like, how do you bake that into when people want to try things? Because, like, if we use an algorithm to identify areas of suicide risk and the algorithm has injustice baked into it, like racism, because we train people on data that may be racist in some ways or biased, then how, and we and we do policy or allocate dollars based on that, then you would have machine learning facilitated social injustice, and you wouldn't want that, especially in our field. Like, and that's just one use case, and Jen's 100% correct.
So that would be, so to make that easier for me to even understand, that's when somebody who's programming an algorithm has an implicit bias that somehow slips into the algorithm and then gets used for
think about it more like this, because when it comes to machine learning or algorithms, a lot of times the machines are doing things that are so complicated that the human's not aware of, but you're training the machine, you're training the algorithm, you're training it on data that has bias, on measurements that have bias, on finding things or looking for outcomes, and those outcomes have bias baked into how you measure them. And for example, if we're doing a keyword search about suicidality and we're using the kinds of things that white female researchers think are important, white female researchers with PhDs think are important in keyword searches, and you might apply that to the social media language that you might see in urban gang youth, which has their social media language has a great deal of trauma and PTSD in their language, and also emoji use and other things. Guess what you're going to do? You're going to undersample and underfind risk areas. And this is the stuff, like, you know, if SPSM had continued, this is the stuff I think I'd be ranting on every week.
Yeah, that makes sense. No, we do rant about this every week too. But that reminds me why we're really here. One of the reasons we're really here is to talk about the AAS board. You've been there for a few years, but and you've accomplished a lot. But I'm wondering what, you know, looking forward, looking into the near future, what do you want? What do you want to accomplish with the AAS board?
So, you know, I think that reasonable people who've been familiar with our organization are aware we've had a leadership transition in the last few months. And from what we know about nonprofits, there are leadership transitions. 1 out of every 10 nonprofits is going through a leadership transition in a given year. These things happen. I had hoped to be wrapping up my board service, quite frankly, and agreed to continue with it in the service of us standing up the new board, which we've seen partially done, having enough, you know, having our board ready to go so that we can continue with all of our business, which we've been doing. We're going to be doing an interim executive director search and looking for a permanent executive director. And we're going to be working on our strategic planning. It was time for our sort of every so many years strategic plan this month in October. So my immediate goals are help this leadership transition happen. And in the process, hopefully, and this is something I've expressed to the board, I've definitely given my service, so I'm looking forward to as we identify our next strategic goals and work through the transition, that they also work through identifying emerging leaders who are ready to serve. Anytime you have a leadership transition, that's a great opportunity for growth and a great opportunity for sharpening your mission focus.
So you don't want to. There's not a whole lot on your plate, even for the next few months.
No, I'm usually really bored with my knitting and my cats.
Bored with the board. No, I mean, I think it's really important for people to understand what has happened even in just the last couple months in terms of getting all the structure where it needs to be and moving forward. And you've obviously been in no small part of that. But you know, I think it also says a lot about what you've been able to do with AAS over the last couple of years and the other board members who've been very instrumental in this. And so I think we owe you a huge thanks for that as well.
I super appreciate that. I will say, here are some things that our board, and I know there's been a leadership transition, but it would be remiss of me to not recognize the folks who have recently transitioned off. But that because of organizational development work that we did, where we worked on intentional strategic planning, where we hadn't done some in a long time, where we worked on how we do board development, educating people about board duties, which we hadn't in some time. And we worked on fiscal stability and development so that we weathered the pandemic and we had good financial health so that we can weather a leadership transition without any financial concerns. And so I know that sounds really boring, and that's not nearly as exciting as the beef that M is here for, right? But those are the fundamentals that nonprofits like AAS are business. And that doesn't mean soulless. It's a business with a mission and that does social good. But in order to do that, board members really look after the sort of mechanics of the business. So for me, it has been, what are the fundamentals of the business? What are the fundamentals legally, the fundamentals financially? What are the fundamentals in terms of operations? What are the fundamentals in terms of strategic planning? So for me, it has been learning and making sure that we have a board that's well grounded in those things. And I would say currently we have on our board more people with more board and leadership and organizational development experience than we've ever had. We also have recruited, and this is not great coming from someone who looks like me, but we have more diversity of demographics, perspective, and sort of position in the community than we have ever had on an AAS board. And for us to have weathered a big leadership transition over the last few months and to have landed on a place where we've brought in even more diversity and even more inclusiveness under the board matters to me a great deal.
And I think that's something that's going to come out in the talks that we're going to have with the additional board members We're also planning on releasing several blog posts that have been written by folks who are more interested in expressing themselves that way, and I'm excited about that because I know these conversations are fun and we get to know and we get to see each other's faces and all of that. But blog posts let someone really express what's important for them. So I'm really excited about those as well. But yeah, I mean, I've been impressed, just super impressed with the folks that I've spoken to so far. And I have no doubt that's going to continue. So we know we could
went all
probably
over the place, right?
we could and I think we did our list of questions entirely backwards, which I think that's not too unusual for us. But and we could probably continue talking for a really long time. But I'm wondering if there is anything as we're sort of wrapping up, if there's anything you want to leave folks thinking about this afternoon.
At the end of the day, the mission never changes and the mission never goes away. I look to the day where we don't need a membership organization about the study of suicidology, because it's one of those illnesses, it's one of those social issues, it's one of those injustices, and there are a lot of ways to look at suicide. It's one of those issues that we have removed as a blight from our communities, and I look forward to that day. And until we get there, here we are, not going anywhere. As long as the mission's there, here we are.
Yep. And thank you, Calvin and Jose and Em and everybody else who jumped on to ask questions and be here to listen about what we're doing and what the board is up to and what April's been up to. And just appreciate you, April, for jumping on this afternoon and having this conversation, answering some good questions, some hard questions, some fun questions. But thanks again for jumping on.
Good to be here and good to see everyone. Great to see Calvin Mann, Jen Carson, Jose Caballos. We had Patty Schaefer and we had M. Tilking. Great to see you.